hello, and I wish you a nice congress. I wish I could be with you there, at least to have a chat, to talk to you. I already missed my Ukrainian friends, but unfortunately, this COVID disease, I couldn't make it. But what I'm going to do is I'm going to give you an online lecture. Well, the topic was actually imaging in brain tumors. Well, what I did, because I checked my previous presentations, and I realized that it takes more than one hour. So I just wanted to focus on meningothelial tumors, the meningioma, especially the meningioma, because it looks like it's easy to report, it's easy to diagnose the meningiomas, but there are some tricks, or and also I just want to mention about them. And also, I just want, because it's very common. Everybody is seeing meningioma almost every day. So I just want to give a brief introduction and give some tricks and tips about the meningioma. So looking at the meningioma, you know, it's the most common non-glial tumor of the central nervous system. So unfortunately, women have more meningiomas than men. They typically are slow-growing tumors, and mostly they are asymptomatic. But if they are symptomatic, then they can cause headache. I saw, especially in the frontal region, I saw many patients that the mental status change, the behavioral change, so they can cause that. And most of them are sporadic, but they may be secondary to previous cranial irradiation, or they can be seen in neurofibromatosis type 2 patients. When you look at the location, I'm not going to give you this, I'm not going to tell anything about this, but they can be anywhere inside the cranium. So they can be anywhere. So I cannot say that they may be located here or there or whatever, but they can be anywhere in the cranium. Looking at the classification, World Health Organization classification, so there are many types. As you can see, there are many types of meningiomas. Well, I'm going to mention about this. If we can make a differential diagnosis, I'm going to tell what I think. But looking at them, most of them are grade 1 tumors, but there are the atypical one. There are some parts that they are grade 2. And of course, there is an anaplastic or malignant meningioma, which is grade 3. So if you have a grade 2 or grade 3 tumor, of course, the pathologist make the diagnosis, then you should think of radiation therapy. Looking at the extraxial tumors, they are dural based, as you can see. They are dural based, with the broad base to the dura. And how do we decide if this lesion is intraxial or extraxial? Then you can have this called the CSF, cerebrospinal fluid cleft sign. As you can see here, you can see the cerebral spinal fluid, CSF, around the tumor. So this is called the CSF cleft sign. So this gives you an information that this tumor is outside the brain. It's not intraxial, but it's extraxial. There are some other signs that can help you, which is called the dural tail sign. As you can see, this is a lesion, but you can see there is a dural enhancement adjacent to the tumor. But don't forget, this is not specific for meningioma. You can also see this in many other tumors. So just please keep this in mind. What also you can see, because in CSF, there are some veins traveling. So if you see also like this hypointense signal void veins between the cerebral parenchyma and the lesion, then the lesion is probably an extraxial lesion. Of course, we can see some changes in the adjacent bone. When we look at the non-contrast CT, the typical features, they are slightly hyperdense to normal brain. When you look at this meningioma or this meningioma, they are slightly hyperdense when compared to the normal brain. You may see calcifications, as in this case here. You may see, but in this case, we don't have any calcification, but you may see calcifications also. What also you can see is actually, you can see hyperostosis in the adjacent bone, like in this case, or destruction, as in this case. So it doesn't mean that, or nothing in the adjacent bone. So you may see hyperostosis, you may see destruction of the adjacent bone, or you may not see any change in the adjacent bone. When you look at MRI, actually, what I want to tell you, typically, they show homogeneous and avid enhancement, as you see, homogeneously enhancing lesion, and they are avidly, they are very early, they show very early enhancement. You may see adjacent brain edema or not. In this case, we don't have any edema in the adjacent cerebral parenchyma. Hemorrhage, do they show hemorrhage inside them? Rare, but you can see it, but it's very, very rare. They are usually homogeneous lesions showing homogeneous contrast enhancement. And also we have, in this case, here we have the dural tail sign, but don't forget, it is not specific for meningioma. You will see, I will show you some other cases when I go to the differential diagnosis. So actually, so another question is, what kind of meningioma is this? Is this a meningothelial meningioma, fibrous meningioma, or whatever? So the only actually the pathologists can say, so this is a transitional type meningioma. Another case, you see the homogeneous enhancement, and then you see the CSF cleft sign around it. There is no adjacent edema, but there is something, I will come there later on. When you report this case, you should be very careful because it's very close to the superior sagittal sinus. Meningiomas may show sinus invasion, tries to take all of them out, then there may be a rupture of the sinus, which may lead to the death of a patient. So when they are close to vascular structures, actually you should be very, very careful reporting about that. So again,
Чекаємо декілька хвилин. На жаль, перервався інтернет-зв'язок. Зараз ми над цим працюємо.
We see the dural thickening and dural enhancement. So this is called the end-plaque meningioma. So, but with the end-plaque meningiomas, hyperostosis of the adjacent bone is very common. When you look at the meningioma, the size of the meningioma is small, but the hyperostosis is actually very prominent. So they say that this hyperostosis occurs because there is reactive hypervascularity of the adjacent periosteum and new bone formation. If there is enhancement inside the bone, then you should think of intraosseous meningioma. If there is no enhancement, then probably it's only a reactive sclerosis. But if there is actually an intraosseous enhancement, then you should report when you report the case, then you should say that there is also intraosseous component of the meningioma. This is also very, very important. Another case, and this time when you look at this case, the inside of the meningioma is not homogeneous but heterogeneous. And also when you look at the enhancement, some parts enhances more, some parts enhances less, and there is a little bit edema. So when after the operation, it turned out to be that this is a atypical meningioma, which is WHO grade 2. So this is again an atypical meningioma, although it is very small, plaque-like lesion. Then you see that after the operation, it turned out to be a WHO grade 2 meningioma. Well, coming to the perfusion, this meningioma shows hyperperfusion, but the perfusion doesn't work for meningiomas. Please keep that in mind. I will show you another case. So these are two meningiomas. One of them is in the posterior fossa, in the right cerebellar convexity, which shows hypoperfusion. But there is another one, intraventricular meningioma, which shows hyperperfusion. So in any kind of meningioma, hyperperfusion or diagnosis by location. So I was telling about the orbita, and now I go to the pontocerebellar angle. So when you So when you look at the pontocerebellar angle, the differential diagnosis is schwannoma and heterogeneous enhancement, some cystic degeneration inside this. And also schwannomas may tend to go inside the internal acoustic canal and widen it. And when you go to the dermoid, it doesn't show enhancement. But when you do the diffusion weighted imaging, they show diffusion restriction. So you can make the diagnosis the differential diagnosis like that. When you go to the supracellular and paracellular area, then you may also see meningiomas in the supracellular area. When you look at this case, as you see here, there is an enhancing lesion. So many people can report this as a macroadenoma, but just be careful when you look closely, the normal pituitary gland is here. I can see it, I can differentiate it. This is over the pituitary gland. So actually this is not a macroadenoma, but actually this is a meningioma. Well, when you look at the coronal image, I see the normal pituitary gland, but over it, there is actually an anterior clinoidal meningioma at this location. But this is, of course, a pituitary macroadenoma. In this case, we cannot make the differentiation, as you can see here. We cannot make it. I mean, we cannot see the normal pituitary gland. This is a macroadenoma. This is a very, very interesting case. Well, there is a cellular mass, a heterogeneous mass, when you look at it. When you make the dynamic imaging progressively, some part of the mass is enhancing very quickly. The other part of the mass is enhancing very slowly, progressively, but slowly. So what is this? Why is this? Actually, we know that meningiomas enhances very quickly and the washout actually is very late. But macroadenomas, they show late contrast enhancement. So are there two pathologies here? So one post-contrast image, some part is here and the other part is here, as you can see. So are there two different pathologies here? Well, actually, yes, this is after the operation. So we warned the neurosurgeon. We said that some part may be a macroadenoma, the other part may be a meningioma, and we were right. So the meningioma enhances very early, but macroadenomas, they enhance progressively, but very late. So actually, this was a very interesting case. So looking at this case, I don't know if you can see where the lesion is. Do you see the lesion? Well, if you inject contrast, it's easy. So this is again an anterior clinoid meningioma. The normal pituitary gland is, you can differentiate it here, but this is not a macroadenoma. And you can see a little bit dural tail. So this is actually, again, an anterior clinoidal meningioma. What is this mass? Is this a signal void? Is this an anterior communicating artery aneurysm? It shows enhancement, peripheral enhancement. Well, you can do the advanced technique, which is, you see, which is actually CT. Then it's a totally calcified mass. So it means that this is a totally calcified meningioma in the supracellular area. In the intraventricular, when you look at the meningiomas may also be located in the ventricle, inside the ventricle itself. So as you can see, this is a meningioma, homogeneously enhancing lesion inside the ventricle. When you look at the coronal plane, so the more enhancing area over there is actually the choroid plexus. So the choroid plexus is displaced by this big meningioma, as you can see here. And what is the differential diagnosis? The differential diagnosis is choroid plexus papilloma. What is the difference between the intraventricular meningioma, like in this case, and the choroid plexus papilloma? Well, first, just to compare, choroid plexus papilloma, they show more prominent, much more enhancement, just compare with the two tumors. And when you look at the borders in the meningioma, although it's lobulated, the borders are smooth. But when you look at the papilloma, the borders, you see these streaky things going inside and out, inside and out. So there are two things that you can make the differentiation: prominent enhancement in the papilloma, less enhancement in the intravesicular meningioma, and also the smooth borders of a meningioma with irregular borders of a choroid plexus papilloma. Another case is another differential is the choroid plexus carcinoma, but in this case there is almost always invasion of the adjacent cerebral parenchyma and a prominent edema around it. So you can make the differentiation. It's really a malignant, a very bad tumor. One other differentiation is central neurocytoma, but with the central neurocytoma, you see heterogeneous enhancement. There is no homogeneous enhancement. Choroid plexus papilloma, meningioma, they show homogeneous enhancement, but in this case, you see heterogeneous enhancement, so you can make the differential with the central neurocytoma. What is important for the surgical planning when you report the cases with meningioma is actually you should always look at the adjacent vascular structures. Is there any arterial encasement? Is there venous sinus infiltration? Or you should be very careful about the hypervascularity of the tumor. I will show you. So we have this pontocerebellar angle lesion going anteriorly to the cavernous sinus. And when you look actually in this slice, you see the internal carotid artery, the cavernous segment of internal carotid artery is surrounded by the meningioma. And when you compare both internal carotid arteries, if there is an encasement by a meningioma, the diameter of the artery is decreasing. It is compressed by the meningioma. So you must report that internal carotid artery is surrounded by the meningioma. This is very, very, very important. You look at the diameter, this is smaller than the other one. And another thing, if there is superior or any venous sinus invasion, you look at this anterior part of the superior sagittal sinus, you see it is occluded by the meningioma. So it is invaded by the meningioma. You should also report this. Otherwise, as I already mentioned before, there may be a rupture. And again, this time the right transverse sinus is invaded by the meningioma. If it's totally occluded, then the neurosurgeons are not afraid of it. But if it's partially occluded, like in this case, then they are very afraid to make a rupture at the sinus. So what, as a radiologist, we should do, we should always look at the relationship of the meningioma with the arteries and veins. And another lesion, this is intraosseous meningioma going out and in, but where is it located? Just at the level of the superior sagittal sinus. So some part of the sinus is occluded. There are collaterals going to the other side. So the neurosurgeons should know this before. This case unfortunately has died because before the operation, they didn't ask to us as radiologists. They said that, okay, this is an olfactory groove meningioma. Yes, but what is there is that there are signal voids. There are arterial vessels inside this tumor. You can see these enhancing lesions, the arteries, and it's very, very hypervascular. So they should have been warned before the operation. And even in some cases in my country, if we had reported this patient would go embolization first and then would go to surgery. But they unfortunately didn't ask to us. And this was just after the operation, you see there's a lot of hemorrhage. Yes, and 4 days later, as you see, there's a huge brain edema, and unfortunately, we lost the patient. So there are other meningeal tumors like metastasis, hemangioperistoma, and others. I will just show you. So this is a metastasis, as you can see. But if you know that the patient has a primary cancer, then if you see something like that, then you should first, in the first place, you should think about the dural metastasis. So this is not a meningioma, but this is metastasis. Of course, here also you can see it. It's like plaque-like, looks like air-plaque meningioma. But this is, if you know the patient has a primary cancer, then you should first think of metastasis. And even in this case, this is not a meningioma. Actually, this is multiple myeloma, which shows dural tail. As I already mentioned, dural tail is not specific for metastasis. Any dural lesion may cause this enhancement, dural tail, so it's not specific. So I remember this case. Of course, I report the case as a meningioma, but it turned out to be a dural plasmacytoma. Well, this was a professor of pathology. She had bladder carcinoma 1 year ago, and then she came with this lesion over there. And I said that, yeah, don't worry, we have dural tail, and this lesion looks like it's outside the brain. And I said that this is just an incidental meningioma. Well, actually, then it turned out to be a neuroendocrine carcinoma metastasis, even not in the dura, it was intraaxial, it was in the cerebral parenchyma. So what I want to say is it's not always easy to make the differentiation if a lesion is intraaxial or a lesion is extraaxial. This is a case of lymphoma. It looks like actually a meningioma, but this is actually a lymphoma case. That just to make a small case. Well, we have another lesion here. It looks like extraaxial, but when you look inside it, there are many phlovoids, hypointense areas inside this tumor, the vascular structures. It's really look at these vascular structures. It's very, very hypervascular. Of course, this may be a hypervascular meningioma, but if you see a lesion like this, then you should also think of hemangioperistoma. So they are commonly in younger patients compared to meningioma patients. This is a very aggressive tumor. It shows much vivid enhancement and highly vascular. So you see on T2-weighted images as here, you may see phlovoids. So it's better that the neurosurgeons knows that this lesion is hypervascular before they go to the operation, and you see after the operation, they took it out. When you look at the literature, you see cases of meningeal melanocytosis, but I must tell you that this is one from the literature, but really it's very difficult to make the differential diagnosis. So as a summary, you don't forget the meningiomas are the most common, one of the most common intracranial tumors. Again, don't forget dural tail is not specific for meningiomas. So differentiation of subtypes that I already mentioned. Is this a meningoteliomatoous meningioma? Or is this actually transitional meningioma, fibrous meningioma? It's not always possible by means of imaging findings. Differentiation between meningioma grades. I mean, is it WHO grade 1? Is this WHO grade 2 or WHO grade 3? It's not always also possible by imaging findings, but if you see that a meningioma invading the cerebral parenchyma, then you may think of malignant meningioma, but it's not always possible. So what I already told you, that you must report in your reports the relationship of the meningioma either with arteries or with venous structures. So you should keep this in mind. It's very, very important for the surgery planning. And don't forget, I show you many mimics, that meningioma has many mimics. So I thank you for your attention. I hope everything went well and you enjoyed the talk. Thank you very much.